Hello everyone, my name is Precious Idogun. I am a PGY3 internal medicine resident at Sarasota Memorial Hospital Internal Medicine Program at Florida State University. This case report is on plasmablastic lymphoma in an HIV-positive young adult male. It focuses on how lack of insurance coverage and socioeconomic factors such as poverty can contribute to treatment delays and complications, eventually leading to devastating consequences. A 30-year-old male initially presented to an outside facility with complaints of rectal discomfort and discharge. Imaging of the abdomen and pelvis showed a perirectal mass. Pathology revealed a rare aggressive lymphoma known as plasmablastic lymphoma, which is a subtype of diffuse B-cell lymphoma. He was advised to visit with an outpatient oncologist but was unable to do so due to his uninsured status. He then was lost to follow-up and presented 66 days later with left-sided chest wall pain and rectal pain, which is associated with streaks of blood when wiping. Physical exam showed a fungating large rectal mass with brownish-red serosanguinous drainage. Imaging showed a left chest wall mass with rib destruction. Given his uninsured status and already significant delays in starting therapy, the decision was made to proceed with inpatient chemotherapy. However, before treatment could be started and while initial laboratory evaluation was being carried out, the patient developed numbness and tingling in his legs and urinary retention, as well as acute paralysis. Urgent MRI of his spine showed an extradural mass. It was started on IV steroids and underwent surgical decompression. However, the patient remained paralyzed. Initiation of chemotherapy was delayed by 10 days postoperatively to allow for adequate healing time. It was then started on inpatient radiotherapy. However, cycle 2 of chemotherapy was again delayed due to ongoing radiation. During radiotherapy, he developed a large thoracic wound dehiscence that required further surgery and placement of a wind vac. He was eventually able to receive cycle 2. However, he suffered complications including pancytopenia, esophagitis, dysphagia, neutropenic fevers which warranted broad-spectrum antibiotics, and eventually leading to severe Clostridium difficile diarrhea. A few days later, a new 3 to 4 centimeter mass was noted along his perineal area, and restaging scans confirmed disease progression. The decision was made jointly with the patient not to proceed with any further cycles of chemotherapy and to pursue palliative care given his worsening performance status. This patient had treatment delays totaling 88 days and was admitted for 94 days. During this time, he was only able to complete 2 cycles of chemotherapy due to his multiple complications detailed earlier. Studies have shown that patients who are uninsured or have Medicaid commonly have poorer socioeconomic status and advanced stages of disease at presentation, which all contribute to observed survival difference. Young adults with cancer are likely to have a delay in diagnosis because of inadequate health insurance, and they present with more advanced stage of disease. A 4-week delay in cancer treatment is associated with increased mortality for several cancers. Additionally, PBL is more commonly found in patients with HIV. This patient was found to be HIV positive at the time of his initial diagnosis, and regular yearly follow-up and testing would have allowed for prompt recognition and treatment of his HIV with hopeful prevention of AIDS-defining illnesses such as lymphoma. Unfortunately for this patient, that was not the case. Further studies are required to determine the association between adequate insurance coverage, seeking preventive care, timing of disease presentation, as well as overall survival. Thank you.